Okay, so let's start the gastrointestinal module. This currently is spanning over 2 weeks, with an additional week for pancreas, liver, and gallbladder. So hopefully you find this interesting. Okay. Okay, so we're gonna keep this pretty brief. I know it's towards the end of the semester. Let's just start. So the digestive tract starts at the mouth, and you have salivary glands there. And so digestion actually starts in the mouth. Most of the digestion is in your small intestine, but some digestion, for example, with salivary amylase that breaks down some carbohydrates a bit, is in your mouth. You also have an enzyme in your stomach that starts to break down the proteins called pepsin. It's an enzyme that's converted from pepsinogen to pepsin, and that breaks down proteins, or it starts to break down proteins. So just take a look at the general anatomy of the gastrointestinal tract. And just so that when we're going through the different parts, you'll be able to visualize where does this all fit in with everything that's being said. Okay, and refer back to this slide. It'll be helpful for you to understand what's happening. Okay, so the upper gastrointestinal tract is really from the mouth to the first part of the small intestine. Okay, so which would mean the first part of the duodenum. So it's mouth, esophagus, stomach, first part of the duodenum. And why do we choose that as the upper part of the GI tract? Well, we can see all of that with a scope. So then we just thought, well, let's just call it the upper part. We can see it with a gastroscope, which is a scope that goes into the mouth and has a look at the upper GI tract. Okay. So the mouth is involved in, of course, eating, ingestion, mastication, which is chewing, saliva production by the salivary glands, secretes some amylase, which will start the digestive process. So where does digestion begin? In the mouth. The bolus is just the soft, semi-chewed, circular ball of food that the tongue pushes towards the back of your throat, and you swallow it. Okay, and that's called the oropharynx, where the food gets pushed to, and it will be delivered to the esophagus. And with peristalsis, with contractions of the esophagus, it will make its way to the stomach. Okay, and I'm sure some of you have tried this, and I think I mentioned it in one of the classes that you can actually eat upside down. The esophagus has peristalsis that's still going to move it to the stomach. Okay, in the stomach, there's chemical digestion in the form of acid, very powerful hydrochloric acid, and as well, there's pepsin, which I mentioned before. So there's chemical digestion beginning, and there's mechanical digestion from the stomach muscles that contract the stomach and mix the food up until it becomes a semi-solid and semi-digested acidic solution called chyme. And chyme is now going to make its way to the duodenum, which is the first part of the small intestine. Okay, so the lower GI tract is basically made up of the small intestine, the duodenum, jejunum, and ileum, except remember the first part of the duodenum, which is part of the upper GI tract. And this is a long tube. This is about 20 feet long, and it's heavily involved in digestion and absorption. This is where most of the digestion and absorption of food takes place to be delivered to your liver. The large intestine is made up of multiple parts, just so that we can identify them to each other when we're talking. So the cecum, ascending colon, transverse colon, descending colon, sigmoid, rectum, and anus, or an anal canal. And really the main function of this is absorption of water and some electrolytes back into the body. Okay, that's what the large intestine does. And of course to store stool for an appropriate time for defecation, obviously. And that's typically done in the rectum and the sigmoid. Okay, and the large intestine is significantly shorter. It's only about 5 feet. But still, if you think about it, you have 25 feet of small intestine and large intestine. It's a lot of tube in there. So just think of what's the goal of the gastrointestinal system. It's to get nutrients into the body. That is the whole goal. Okay, so if we keep that in mind, then it'll make sense about why all these things are happening in terms of secretion and what's the pancreas doing, what's the bile doing. The whole goal is I want these nutrients that I'm putting in my mouth. Okay, so ingestion occurs in the mouth. The food is taken to the stomach. There is a bit of digestion in the stomach with pepsin that breaks down the proteins a bit. And then the vast majority of digestion with lipases to break down fat, proteases to break down proteins, and all kinds of amylases and other carbohydrate enzymes to break down all the carbohydrates in the small intestine. Okay, and then absorption. So you've broken down the nutrients to smaller molecules. Now the absorption will take place into the bloodstream and to the liver. So the stomach, we'll get to it a bit, it has very little absorption. Small intestine, the vast majority of nutrient absorption is in the small intestine. The large intestine, so when fluid is flowing from your small intestine to your large intestine, it's very liquidy still. And the function of the large intestine is to reabsorb all of that fluid, since the body requires fluid, okay, to maintain its circulatory system. And as well, electrolytes are reabsorbed. Okay, so now elimination, okay, well, the large intestine is responsible for that. Elimination and storage of stool is really the large intestine. Okay, so try and separate the different parts of the GI system to what their main function is. Okay, and it's all about getting nutrients and water into the bloodstream. Okay, so I'll just discuss the mouth problems. So, I mean, oral problems are an issue because if you have painful oral conditions, then it's very hard to eat and drink. Okay, so let's just go through a couple of these. So the first one is thrush, candidiasis. So it's a yeast infection of the mouth. Who gets these? Young infants. People that are immunosuppressed can have thrush. And in particular, people that are on steroid inhalers can get thrush. Because the steroid inhaler, if you're not rinsing your mouth afterwards, it deposits on the back of the mouth and it predisposes you to colonizing with yeast, and you can get thrush. Otherwise, thrush is relatively rare in a healthy adult. Okay, thrush in a healthy adult is an indication that something else can be going on with the immune system. Herpes simplex 1 is a viral infection. It's recurrent. Most of us acquire HSV1 in childhood, and then it becomes a recurrent cold sore for us over the rest of our lives. There is treatment for it if people do want to take something. Every time an outbreak occurs, there's antivirals in the acyclovir group. Most people don't do that. I would say most people just treat it locally with creams because it tends to dry out and bleed and crack. Stomatitis is just a general term saying I have inflammation of the mouth. Very common after chemotherapy. It can occur in some chronic diseases, and we often treat it symptomatically with a variety of different oral solutions to try and settle down the pain so that people can still consume fluids and food. An aphthous ulcer, they're usually discrete little ulcers like the one in this picture. That's a perfect example of one. It's either on the tongue or on the side, the inside part of the mouth, also called a canker sore. Again, we use different solutions. The solutions are often a mixture of some kind of a freezing agent like lidocaine. Sometimes they have a bit of an antibiotic mixed in them. Sometimes we add a bit of Benadryl to this whole mixture. And often we add an antifungal solution to it. So you can see that we don't really know the cause because we're adding 4 or 5 things to this solution, and we get people to mix or rinse their mouth with it to see if we can get rid of it. And they're quite painful, especially if you're eating acidic type foods. Oranges, tomatoes can aggravate them, and they typically just self-resolve. Okay, on to the gastroesophageal junction, or the lower esophageal sphincter, or the squamocolumnar junction. And these are all the same terms for the valve between the lower esophagus and the upper stomach. Okay, and we need that valve to be functioning so that acid isn't continually refluxing back into the esophagus, which harms the esophagus. It creates acid burns in the lower esophagus that then leads to an assortment of symptoms and conditions. So that valve is really needed. And when the valve is not strong enough, for a variety of reasons that we'll come to, you will get symptoms of heartburn, right? So burning sensation in your chest, possibly burning sensation and reflux of fluid all the way up into your mouth. So we'll come to those. We'll come to those symptoms. But just remember, the acid in the stomach is very caustic to the lower esophageal tissue. Okay, so gastroesophageal reflux disease, or GERD, okay, extremely common. Many of us have this, and many of us have had to take antacids to try and settle down the acid in the stomach so that even when the fluid is refluxing, it's not as acidic. Okay, so really what happens is that there's juices, gastric juices, reflux back into the esophagus, causing irritation of the lower esophagus. Okay, and the irritation is really a form of burning because of the very low pH of the gastric juices. So what kind of symptoms? Well, heartburn is just the term used for I have this sensation in my lower chest of burning, of discomfort, and that's the esophagus that's inflamed, right? Esophagitis. Abdominal pain. Sure, so you can get lower chest pain or epigastric pain, which is right in the pit of your stomach. And you get that, again, because the esophagus is saying, I'm really inflamed here. I'm getting burned. Chronic cough. Well, a chronic cough, people with GERD, when they're lying down at night, they can reflux all the way back up into their mouth, and they can actually aspirate some of this acid into their respiratory tract. So if you're aspirating at nighttime, just a bit of tiny acid into your respiratory tract, you'll be left with chronic irritation of the respiratory tract. And this is one of the most common causes of a chronic cough, is GERD. Okay, so the other one is postnasal discharge, where people are lying down and you're getting nasal discharge dripping down the back of your throat, causing a cough. The other one is reflux of acid that's irritating the respiratory tract. Okay, so people can wake up in the morning with a sore throat because the acid burned the back of their throat. Nasty taste in the morning because you've had stomach contents refluxing back up. Okay, so let's talk about some risk factors that's going to put people at risk for getting reflux of acid into their esophagus. So anything that puts more pressure on your abdomen is going to put more pressure within your stomach, which is then going to force fluid up into the esophagus. Okay, so obesity, especially abdominal obesity, more pressure on the abdomen, more fluid refluxing. Pregnancy. Women often get heartburn in pregnancy. The organs are running out of space. The enlarging uterus is moving other things out of the way. And one of the things that moves out of the way is the stomach. So there's more pressure on the stomach and reflux occurs. Hiatus hernia is just a condition where, and we're going to talk more about this, so I almost feel like skipping it. It's just a condition where the lower esophageal valve isn't working well because some of the stomach has herniated, has moved into the chest cavity, and so you're more at risk for refluxing of acid. We'll come back to that. Certain medications can put you at risk for reflux disease. So sedatives and birth control pills, why would they put you at risk for reflux disease? Well, they relax the lower esophageal sphincter, right? So if you're relaxing the lower sphincter, acid can more easily get into the esophagus. Okay. NSAIDs. Well, NSAIDs are direct irritants on the stomach, and by directly irritating the stomach, if you have any reflux, you're actually refluxing. Actually, you know what? Let me rephrase that a bit. So sedatives and birth control pills relax the lower esophageal sphincter. NSAIDs would be medications that would bother the stomach more. They would lead to stomach irritation, ulcers of the stomach, gastritis. They don't tend to aggravate reflux disease. So let's come to another condition. So gastroparesis, it just means lazy stomach. So why does lazy stomach, what is lazy stomach? Well, the nervous system, so the gastrointestinal tract has its own nervous system, the enteric nervous system. And diabetics in particular, you know that they run into problems with neuropathies. So neuropathies of their leg. They can get neuropathies of the stomach, and the stomach doesn't contract very well. It doesn't move the food forward into the duodenum. So they're more at risk for reflux because the stomach isn't emptying. And we do have medications that can help empty the stomach faster to avoid reflux disease. Okay. Large meals. Well, large meals, especially at bedtime, more pressure in the stomach. And now you're going to lie down in bed, which is going to put more abdominal pressure since you're not standing up anymore, especially if you're pregnant or if you're obese. And that's going to cause reflux. So we often tell people, don't have a large meal before going to bed. Eat smaller meals through the day instead of 3 large meals if you have heartburn or reflux disease. Okay, what about diet? Fatty foods, caffeine, and alcohol. Well, caffeine and alcohol, they're irritants to the lower esophagus. they're also irritants to the stomach. Fatty foods tend to have a bit of a relaxing effect on the lower esophageal sphincter. So I would try to link gastric irritants. So if you drink 10 cups of coffee today, you're going to have an upset stomach. If you have 10 beers today, you're probably going to have an upset stomach, gastritis. If you take 10 ibuprofens today, you're going to have an upset stomach. And that they can also lead to some reflux disease because you're actually irritating the esophagus as these things are being swallowed as well. Okay, so I guess it's fair to say that NSAIDs can cause some esophageal irritation and reflux disease. Okay, so let's look at some acid suppressors. Let's start with the most common, the PPIs, proton pump inhibitors, and they have direct action on the proton pump, which is responsible for the acid, H+, for getting into the stomach lumen. So if you can directly block the proton pump with one of the PPIs, such as omeprazole or pantoprazole, remember the ending there, then you really reduce the acid in the stomach. Okay. The other common group are the H2 blockers, histamine receptor blockers, such as cimetidine, ranitidine, and another one called famotidine that people might know it from Pepsid as Pepsid. And because histamine activates the parietal cell to produce acid, well, if you use an antihistamine, such as one of those, then you'll reduce the acid in the stomach as well. Cimetidine is used less commonly now because it doesn't get along with a lot of drugs. So we often had to look up other drugs to make sure that there was no interaction. And as well, it tended to cause a bit of gynecomastia, slightly enlarged breasts in males. So kind of backed away from that one and we use ranitidine much more commonly. Misoprostol is another medication that's used to reduce acid. It's not as effective as PPIs, so it's definitely not as common anymore. And the other reason it's not as common is it causes tremendous abdominal cramping and diarrhea in some people because it has stimulant effects. So another way to remember this drug is, well, what else do we use it for? Remember, we use misoprostol to activate labor. We use it to promote stronger contractions in labor because it contracts the uterus. Sometimes we'll use it to slow down postpartum bleeding because, again, it contracts the uterus. So because it causes contraction of the uterus, you would never use this in someone who's pregnant unless you wanted to induce labor. So it's kind of doing the same thing in the gastrointestinal tract. It's causing cramps. It's contracting things. You're uncomfortable. You have diarrhea. So it's just with time we use it less and less. Okay, so let's do this question together. What are some lifestyle modifications that could improve a patient's gastroesophageal reflux disease? So select all that apply. So eating large meals definitely is going to aggravate GERD, right? So when you fill the stomach with more food, it's going to create more pressure. And if you have a weak esophageal valve or sphincter, it will be overcome by the pressure of all the food in the stomach, right? So eating smaller meals, but more frequently, can be a suggestion instead of having large meals. Okay. Avoiding caffeine. Well, caffeine is a gastric irritant. So if you have anything that's irritating the, the stomach, or it can also lead to relaxation of the lower esophageal sphincter and create more GERD symptoms. Okay. Weight loss. Well, by losing weight, especially abdominal weight, there's less pressure on the intra-abdominal organs, including the stomach. And if there's less pressure on the stomach, there's less chance that acid is going to reflux up into the esophagus. Okay, so that would also be an answer. Improved sleep, even though that's a good idea, that's not going to help gastroesophageal reflux disease. Okay, so think of anything that can irritate the stomach, spicy foods, alcohol, eating large meals, caffeine. Those are all going to, NSAIDs as well, by the way, so non-steroidal anti-inflammatories. They're all going to irritate the stomach and potentially cause more GERD symptoms. Gaining weight, pregnancy aggravates GERD for sure, right? So think of GERD as, okay, what's the pressure within the stomach and what's going to aggravate that pressure and cause acid to reflux back into the esophagus?